Okay. Good afternoon again.
Good afternoon, sister.
Yeah, last week we discussed bleeding in early pregnancy. And this week we are going to discuss bleeding in late pregnancy. Bleeding in late pregnancy, we all know, has to do with abruptio placenta and placenta previa. Now, when we talk about placenta previa or abruptio placenta, we are talking about vaginal bleeding that occurs late in pregnancy. At that time, the fetus is viable. And where it is abruptio, the placenta is normally situated, but it begins to detach prematurely, maybe because of a trauma, a disease condition or something. But when we talk about placenta previa, it is abnormally situated in the lower uterine segment. So, abruptio placenta is the premature separation of a normally implanted placenta from the uterine wall after 20th week of gestation. That is, after 20th week, remember we had said that before we used to say a fetus is viable after 27th week, but today we are saying after 20th week. Probably the best definition will be when the fetus is viable. When the fetus is viable. Any period from that time until second stage of labor, because it should separate in second stage of labor. That is when it should actually start separating. Obstetric hemorrhage. Obstetric hemorrhage that comes from abruptio is ranked as the first cause of maternal mortality, and it accounts for 25 to 50% of maternal deaths. Epidemiology and causes. Of course, we know that bleeding in late pregnancy is called antepartum hemorrhage. And we are told that 4% of women develop antepartum hemorrhage. The causes of antepartum hemorrhage could be abruptio placenta, 1 in every 100, placenta previa, 1 in every 200, then uterine rupture, which is not common. It is not common, but most times you could have it in scarred uterus. When you have it during obstruction, then I would want to call that mismanagement. If you have the bleeding when there is vasa previa, then it is between 1 in 2,000 or 3,000. In other words, it is not common. Local causes could be a bloody show, and so when you see that, you are worried and you think she is bleeding. Cervical polyps, cervicitis, or cervical ectropion. When you see that, you worry. Now, when we look at this, you will see the normal situation of placenta. You can see the placenta up there. And then when we talk about abruption, placental abruption, you can see the middle one has started separating there. And then the previa, the placenta is lying right across the uterine os. Abruptio placenta, early separation of normally implanted placenta after 28 weeks of gestation. Now we have come to it. And before the end of second stage of. And when we talk about it could also, there is risk of recurrence of abruption in subsequent pregnancy. And we are told that that risk is high. Epidemiology of abruption, it occurs in about 1 to 2% of pregnancies, 20% of all third trimester bleeders. And again, there is recurrent risk. The recurrent risk is that if she had abruption in, or rather 10% of abruption happens in first pregnancies and about 25 in second pregnancies. In other words, if she had in her first pregnancy, there is a tendency that she will have it again. It is a significant cause of perinatal mortality. And we are told that this is 15 to about 20%, while maternal mortality carries about 2 to 5% of mortality, of death, yeah. Now, risk factors. The prevalence is high in smoking or substance abuse patients, history of previous abruption, that is recurrence, high birth order, advancing maternal age, poor socioeconomic conditions, malnutrition, and placental insufficiency. So these are risk factors to abruptio placenta. And then risk factors, you have them here: maternal age and parity, that is high rate of delivery, cigarette smoking, the kind of drugs, multiple pregnancy, chronic hypertension, mild and severe preeclampsia, chronic hypertension plus preeclampsia, premature rupture of membranes. And then when you have oligohydramnios, chorioamnitis, then the diet, what? What is the diet what? Who can help me read that?
Dietary or nutritional deficiency.
Sorry?
Dietary or nutritional deficiency.
Well, since you can see it. And then there is a point that I cannot really understand, and I have not looked up for it. That is my fault. Male factor. I don't know why the male factor should be a susceptible condition for abruption. Then etiology, we have hypertension in pregnancy, and these are all the things that come under hypertension in pregnancy. You have trauma, and that trauma could be external cephalic lesion, road traffic accidents. When maybe there is need for amniocentesis, you could have a needle puncture. Then you have sudden uterine depression. Delivery of first twin could cause it. Sudden escape of liquor amni, particularly in where there is tap. Then premature rupture of membranes. Again, sudden collapse, sudden decompression of the uterus. Short cord, supine hypotensive syndrome, placental anomaly, the placental insufficiency, like we're talking about the sick placenta, folic acid deficiency, uterine anomaly, and then the thrombophilias. Still talking about the causes. Then the pathogenesis. There is something I want us to look at. Okay, the RTA, it could be RTA, it could be a fight, it could be a fall, and there is a heat on the abdomen. Then the pathogenesis. When you look at the causative factors, as we've just talked about, they cause hemorrhage, and this hemorrhage, the bleeding is into the decidua basalis. When it is between the endometrial lining and the decidua basalis, some people call it basalis, however you want to call it, but I know you understand. This initiates placental separation. Then you come down to the decidual hemorrhage that is going on already, that is causing that separation, leads to degeneration and necrosis of the decidual tissues and adjacent placental parts. And when that happens, there's separation. So here, there becomes asphyxiation. Why? Because the oxygen is cut off. You look at this slide here, you are looking at the umbilical vein, and you are looking at the umbilical artery. The umbilical vein carries oxygenated blood, while the artery carries deoxygenated blood. Now, when there is abruption, the uterine veins and the uterine arteries are separated. And because of that, they cannot nourish the fetus via the placental vessels. And then abruption with trauma. Again, the placenta shears off because there is trauma. The myometrium that is supposed to be elastic stretches and cannot stretch further. When that happens, bleeding comes up. You have the uterus, ABC. The A gives you concealed hemorrhage. The B gives you revealed hemorrhage. While in the C, it is both concealed and external hemorrhage. Features of retroplacental clots. You have number one, depression found in the maternal surface of the placenta. Number two, you also have areas of infraction with varying degree of organization still in the uterus. Classification. Classification is based on the extent of separation. Number one, the extent of separation could be partial or complete. Number two, location of separation. That location could be marginal or central. Number three, clinical presentation. Clinical presentation, the bleeding could be external, could be concealed or mixed. When it is external, it is revealed. When it is concealed, you cannot see it. When it is concealed and mixed, some is hidden, some is seen. Then when you talk about the fourth classification is clinical severity. The mild, the moderate, and the severe. Then clinical severity. Grade 0 has no clinical features. Diagnosis is made after placental examination. Grade 1, mildest form, approximately 40% of all cases. And under grade 1, no vaginal bleeding to mild vaginal bleeding. Slightly tender uterus. There is normal maternal blood pressure and heart rate. No coagulopathy, that is no clotting problems. And there is no fetal distress. Nana, mute yourself. Then grade 2, you have, it is, we are told it is moderate. You have approximately 45% of all cases. Again, no vaginal bleeding to moderate vaginal bleeding. Moderate to severe uterine tenderness with possible tetanic contractions. Maternal tachycardia with orthostatic changes in the blood pressure as well as the heart rate. There is fetal distress. There could even be death. The fibrinogen level varies. And when there is low fibrinogen levels, there is bound to be clotting problems. Then clinical severity, we continue. Grade 3, this is the severe form. Approximately 15% of all cases, no vaginal bleeding to heavy vaginal bleeding. Very painful tetanic uterus, maternal shock, coagulopathy, fetal death. Just hold on. Hope you are fine. I'm fine. No one, I was just to say hello. No, please come. Please come in.
You're having class?
Yes, I'm having lecture.
Oh, okay.
Please, how do I pull this? It is one of these ones that you pull out. When it was brought, it was easy to bring out. And that was last week. Shikenanko. God bless you. You just hold it up.
Yes, you don't press anyone. You want to charge this?
Yes, please.
Oh, okay.
Then pick one there.
Oh, okay. Thank you. God bless you.
God bless you.
I'll be in the office for a while.
Oh, okay.
Yeah.
Class, give me a few minutes.
Okay, sister.
Yes, I had a challenge and that challenge has just been resolved. All right. So the features, the spin and tenderness, initially localized, then it becomes generalized due to endometrial injury. You have the extravasation of blood that has gone into the endometrium could cause that. You also have vaginal delivery, bleeding, and maternal distress, of course, intrauterine fetal death. Clinical manifestation. When we talk about the concealed type, the blood accumulates behind the placenta. The revealed type, the blood is dissected, or it dissects downwards between the membranes and the uterine wall, and ultimately it escapes out through the cervix. That is when we are talking about the revealed bleeding. But remember that even as it is coming out, some is concealed. Not all comes out. Why? Because of the closure of the fetal head in the lower uterine segment. I want to believe I am teaching undergraduates. Am I correct?
Yes, bro.
Yes.
Because at a point I'm getting confused. I hear children and I begin to wonder whether this is a kindergarten class. Mute yourself where your children are with you. So you look at this diagram, the red part there is the placenta, the placenta. Then the gray there is the concealed bleeding. So you can see it could be external or concealed as we have seen it there. Clinical manifestation of hemorrhage. Blood may gain access to the amniotic cavity after a rupturing of the membrane. That is quite serious. Then you have the covelary uterus. When it happens like that, blood pre-collates, that is, it takes over the myometrium completely. It pre-collates through the layer of the myometrium, and you see the uterus looking very dark patches around. There you have the covelary uterus. With the naked eye, the covelary uterus looks dark. That is, you have it in spots. The color is wine color, maroon. It is patchy and diffused. Subperitoneal petechial hemorrhage is seen. That's the dark ones that you see. Then you have free blood, which may present in the peritoneal cavity. As the blood gets in, rupture could happen anywhere. Before you begin to say, how does it get to the peritoneal cavity? The question you will want to ask yourself before you ask that is, how did it get into the tissue? How did it get into it is supposed to be in the myometrium. That is in the uterine cavity. But it seeps into the tissue and in the same way into the peritoneal cavity. That is, we have seen with the naked eye. With the microscopic appearance, you find necrosed uterine muscles in all the affected part. Then blood infiltration between the muscle bundles. Blood vessels may show acute degenerative changes. Muscular dissociation occurs. That is, the muscle tissues dissociate. Occurs in the middle and outer muscle layer. Clinical features. When what the symptoms you will see when the blood is revealed or when it is concealed. And definitely what I want you to have at the back of your mind is that once it is concealed, it is mixed. So symptoms. In revealed bleeding, abdominal bleeding, and discomfort followed by the bleeding. Prof, what do you mean by abdominal bleeding? The bleeding, the abdomen is distended, is tetanic, is painful. Then you know she is bleeding inside. In mix, there is acute intense abdominal pain, followed by slight bleeding. Characteristic of bleeding in revealed. It is continuous, but dark in color. In the concealed, continuous dark color or serum, serous discharge. General condition. The general condition is that the bleeding could be proportionate to the visible blood loss. Shock is usually present. For the concealed or the mixed, shock may be pronounced, which is proportionate to the visible blood loss, and then the pallor related with visible blood. The pallor is usually severe and out of proportion to the visible blood. Then the features of pregnancy, oh my God. Pauline and Tim, please mute yourself. Phoebe, mute yourself.
Hey, no, when is on your papa? I'm going to find time. Boy.
Who is the person?
Hello.
Yes, Phoebe, what can I do?
Hello. I saw you instead of your end.
Hello, sister.
Phoebe, what's the problem? The uterine height. It could be proportionate to the period of gestation that is under revealed, but under mix, disproportionately enlarged and globular. Uterine feel, normal feel with localized tenderness. Contractions frequent and local amplitude. But under mix, the uterus is tense tender and rigid. Fetal parts can be identified easily. On the other side, it is difficult to make out. Fetal heart sound usually present, but when we come to mixed, it's absent. Ultrasound in this condition. Abruption is a clinical diagnosis. That is, it is what to diagnose clinically. Placental location and appearance. Then when you look at it, you will have retroplacental echolens, abnormal thickening of placenta, torn edge of placenta. The fetal lie could be abnormal or normal, but it will be seen. Then estimated fetal weight. That is the large extent of the sonographic preplacental location lying beneath the chorionic plate. And then this one again, the retroplacental clot is also observed during abruption. It also lies between the placenta and the uterus. Then the blood collection at the placental margin. If you see where the arrow is, you will see that there is an edge there. Oh, sorry, a ridge. That is the placental margin. Then, of course, the laboratory tests. The medical officer will want to know the complete blood count, the type, and then the rhesus. All these ones here, you don't bother yourself about them. Now, Shear's classification of abruption. He classified abruption into 3 grades. Grade 1, mild, often with retroplacental clot identified at delivery. Ordinarily, you will not know, just like the first one we looked at. Then grade 2, tense, tender abdomen, but the fetus is alive. Now, when we come to grade 3 has to do with fetal demise or without fetal demise. Now, when there is fetal demise, there could be coagulopathy. And then the other one without coagulopathy. So you see that the grade 3, as far as Shear's classification is concerned, is talking about whether the fetus is alive. And if that fetus is not alive, is there coagulopathy present? If that fetus is not alive, is it a still baby with without coagulopathy? So 2/3 come without coagulopathy, and then 1/3 with coagulopathy. And for coagulopathy to be present, it means the fetus has died for some time and has started decomposing. Then complications. You have shock, acute renal failure. What could be the cause? Seriously impaired renal perfusion. 2nd degree. 2, reduced gaseous exchange and intrarenal vasospasm. That is the type you see in preeclampsia. And then dilatation, insufflation, and curettage. So that when you have consumptive coagulopathy, up to 2 degrees, then you are suspecting hypofibrinogenemia along with elevated levels of fibrinogen or down to fibrin degradation products. Sorry, I just suspected that is fibrinogen to fibrin degeneration products. But since you can see it, you are okay. Now you have fetal distress or demise. You have postpartum hemorrhage. Then, of course, the covariary uterus, where you have widespread extravasation of blood into the uterine musculature and beneath the uterine serosa. Then you have the Sheehan syndrome. You have the puerperal sepsis. Of course, you cannot have the covarious uterus and you don't talk about puerperal sepsis. And then the management. Our prevention is aimed at eliminating the unknown factors. Number 1, correction of anemia. Number 2, and prompt detection and institution of the therapy to minimize complication. That's what we do. You want to find out what the causative factor is. And because she is bleeding, she is anemic, you want to correct anemia, knowing very well that where anemia exists, there are a lot of complications. And then prompt detection of what is present and then institution of treatment. All this to reduce complications. Then, where the factor, the causative factor is known, early detection and effective therapy. If it is a needle puncture, you use the USG to guide. Avoidance of trauma. Avoid sudden decompression of the uterus, very important. Avoid supine hypotensive syndrome, and then routine administration of folic acid. Management depends on fetal maturity, degree of severity, and viability of the fetus. When the fetus is distressed, and when you know that the fetus is not viable, why manage? That's number 1 question. How will you approach the management? So management for this condition depends solely on these factors. Assessment of case. What is the blood loss? How mature is the fetus? Is that patient in labor or not? Are there complications already present? What is the degree of abruption? Those are the things you assess before you begin to manage. Then emergency measures. You have to ensure that her blood is sent to the lab. You want to know the level of HB and the hematocrit. You want to know the coagulating profile, ABO and rhesus grouping, to know whether whatever is happening, the fetus and the mother, are they compatible? The blood you are keeping, will it be compatible with what she has? Then you have to send urine for detection of protein. You give intravenous ringer lactate. When you are doing it, the cannula should be, the bowl should be big. All what you're doing is that you're preparing for blood transfusion. Then close monitoring of both the mother and the fetus. The mother and the fetus well-being is called for because already the condition is critical. Treatment modalities, expectant management of pregnancy, that should be definitive. What do you want to do? Define. Are you going to do induction? Are you going to augment the labor, or will you do a cesarean section? The mode of delivery should be definitive. If the patient is in labor, low rupture of membranes, augmentation, again, depending on your assessment. Bedside clotting time should be done regularly. If you are considering vaginal delivery, it should be limited to placenta abruption. In other words, what is the degree? Is it first degree? Is it first grade? You should be sure of the fetal heart sound. You should have facilities of continuous fetal heart sound monitoring. And then prospects of vaginal delivery is soon. She cannot withstand long vaginal delivery. So you do a vaginal examination, you monitor the progress of labor. And then placental abruption with dead fetus. Again, you must make sure that that labor will not cause more harm to the woman, knowing very well that the fetus is not alive. When the patient is not in labor and bleeding continues, and the separation is grade 1, you deliver either by induction or by cesarean section. In this one, the obstetrician will decide. General management. Number 1 is delivery. Number 2, resuscitation. And then number 3, you talk of whole blood and IV fluids. You monitor the patient's vitals, and then catheterization to monitor the output because there is input. Number 2, cesarean section. Indications for cesarean section. Number 1, you want to salvage the baby. Number 2, you want to control severe bleeding. Number 3, the progress of labor is poor. Number 4, the lie could be transverse, or the pelvis is inadequate. Then you have post-delivery watch out for postpartum hemorrhage. The myometrial myofibrin lose contractility. Once you find out that the uterus is not contracting, you must move fast to ensure that woman does not pour. And that is why when these conditions are present, and the progress is slow, cesarean section is called for so that as she is opened into, all the products of conception are removed. Everything is cleaned. The inside is cleaned up to avoid retention of anything that might warrant postpartum hemorrhage. Again, when you talk about expectant management, number one, you must make sure that it is grade 1. That fetus is reactive and remote from 10, and then the bleeding has stopped. What is the goal? You have the goal there to prolong pregnancy. Meanwhile, you administer whatever is prescribed that will help in this case. Please, your questions. Hello. Yes, Josephine.
Yeah, good afternoon.
Good afternoon.
Hello. Please, in your presentation, you mentioned a word in ultrasound that there is retroplacental equivalency. Please, can you highlight it a bit?
Yeah.
And then the second question, you also said that once there is covalent uterus, there cannot be pepperal sepsis. So I wanted to ask why
is talking
is that?
and another person is talking. Edna, can you please mute yourself? Josephine, your second question, please.
Please, you also mentioned in the under the shares classification that once there is covalent uterus, there will also be pepperal sepsis. So I want to ask why it is so.
Pepperal sepsis.
Thank you.
With the covalent uterus, there is seeping of blood into the tissue. And once that happens, there's bound to be infection. I explained that as I was talking. Such an individual, such an organ is susceptible to infection. That one is not a question. Hello?
Yes.
So there is bound to be infection when it happens like that, because the blood has polluted. It is now a foreign body in that tissue. Blood is supposed to be in the veins. And then it is sipped in a particular quantity, in a required quantity to nourish the tissues. But the blood, number one, has been separated. Note that that blood is very dark. It's already polluted. And so it seeps into the tissue. There's bound to be infection. I don't know whether that's okay.
Yes, sister. Thank you very much.
Thank you. Then the second one, you go to the net. And let us have, because that's what I teach you people. Every time, go to the net. We are waiting for the answer from you. Meanwhile, we want to discuss placenta previa. Placenta previa is a partially or wholly attached placenta to the lower uterine segment. The incidence again, The incidence of placenta
So this one.
previa is, we are told that it is 0.5 of pregnancies. More common in multiparous and in twin pregnancy. Why? Due to large size of the placenta, number one. Number two, due to the roomy pelvis. So the placenta is large. The uterine cavity is roomy. So it just floats to any side it likes and it settles. I use this illustration. When you come to the classroom or you enter the church, no, when we talk about class now, not the virtual class, the physical class, and you are the first, you choose anywhere you want to sit. True or false? You choose anywhere you want to sit. But by the time you come in and the church is full, you are forced to sit where you are asked to sit. That's the issue. There's somebody, either, I don't know whether it is Mercy or somebody whose system is making noise. Mercy. Mercy, mute yourself. What could cause abruptio placenta? The cause is not well known, but we are told that it could be due to low placentation of the blastocyst. Development of the chorionic villi in the decidua capsularis, leading to attachment to the lower uterine segment. In other words, the development of the chorionic villi is in the decidua capsularis. And so with that, it leads the placenta to be low-lying. And then you have large placenta in twin pregnancy. Degrees or types. There are 4 types. Type 1, the first degree. This is called placenta previa lateralis. It is low-lying placenta. And if you look at it there, it is just the lower edge of the placenta that reaches the lower uterine segment. But it does not get to the uterine os. To the internal os, rather. Sorry. Then second degree of type 2 placenta marginalis.
Hey, Mami Bessie,
Rita, mute yourself. Rita, mute yourself. The lower edge of the placenta reaches the margin of the internal os, but does not cover it. It does not cover it. That is that. It has reached the margin, but it does not cover it. Then you have third degree or type 3 placenta previa. This one is incomplete centralist. The placenta covers part of the cervical os. The placenta covers the internal os when that os is closed, or when the internal os is partially dilated, but not when it is fully dilated. So you can see it there. It has covered it. The os is closed. Looking at the edge, when it starts dilating, it will begin to separate. Then you have the type 4, or the 4th degree. This one is placenta previa complete centralis. Placenta completely covers the internal os, even when the cervix is dilated. The placenta covers the internal os completely, whether the cervix is partially or fully dilated. You can see it mounted there. Josephine, are you all right? Can we hear you? Or are you using your phone?
Sister,
Yeah.
it says that it is also commonly referred to as the retroplacental clear space, hypoechoic zone, or sonolucent zone. That's a medical term used during prenatal ultrasound examinations to describe the dark or clear-looking area located directly behind the placenta, separating it from the muscular wall of the uterus. That's the myometrium.
Okay. Separating the dark portion from the myometrium.
Yes, please.
Thank you.
Thank you, sister.
Note: placenta previa marginalis posterior is of bad prognosis. That is, it is more dangerous than placenta previa marginalis anterior.
Either one. Is the place? Where's the place? Okay.
Dorothy, mute yourself. The reason is that it encroaches on the true conjugate diameter, delaying engagement of the head. Engagement of the head will compress the placenta against the sacrum. And of course, if that happens, there is fetal asphyxia, which will be very terrible. Mechanism of bleeding. Progressive stretching of the lower uterine segment normally occurs during the 3rd trimester and during labor. But the inelastic placenta cannot stretch with the lower uterine segment. This leads to inevitable separation of a part of the placenta with unavoidable bleeding. I want you to grasp that mechanism before we continue. What this session is saying is that the lower uterine segment stretches, but the placental tissue cannot stretch. And so, while the lower uterine segment begins to stretch, in order to dilate, to allow the passenger and other products of conception to be expelled, the placental tissue cannot stretch. And so there is separation. And once that separation takes place, there's bound to be bleeding. That bleeding, no matter what you do, cannot be avoided. Number one, the lower uterine segment at the end of pregnancy must separate. It separates inevitably. Patients, mute yourself. Ah.
Yes.
So the closer to 10, the greater is the amount of bleeding. Closer to 10 because the cervix. I don't know. I have not been made a co-host. So people like class rep, are you the co-host? If you are, put patients outside.
Prof, please, you are a co-host.
Yes, madam. Look at it. When I click, I am told ask to mute or ask to, it doesn't mute. That's why I had to call you. I have been trying to do it many times. What do you mean by patient or student? Gloria, what do you mean by that? Diagnosis. When we talk about bleeding, or when we talk about placenta previa, it's simple. The bleeding is causeless. The bleeding is painless. And it is a recurrent bright red vaginal bleeding. Ask the woman what happened. She will tell you nothing happened. Most of them is usually at night when they are sleeping. So the symptoms, bleeding is causeless. Even though we are told that it may follow sexual intercourse or vaginal examination. For vaginal examination, she already has come in with the history of bleeding and the symptoms. So for such an examination, it must be done under anesthesia. But this bleeding is painless. It is not in all cases that it is associated with labor pains. It is recurrent. It is bright red. We are told here that the fourth sign is that the first attack is usually not severe. So probably she wakes up and sees that she is bleeding, she packs herself, it controls. But when it comes again, it is severe. That is why some women may see that, they pack themselves and say, okay, let us wait till morning. And the next minute, they start bleeding uncontrollably. I know of a history of a woman who got up at night and felt like easing herself. She sat in the toilet and she was voiding continuously. It wasn't stopping. What I don't understand is the fact that she could not discern that this liquid that was coming out was not from the bladder. Because when your bladder is full and you empty it, you have a relief. She sat down there and it was oozing out. She didn't have any lights with her. She now called out to her husband to please bring light. And by the time they came with light, the whole toilet sink is filled with blood. The husband lost that lady. Because after that, I don't know what caused the delay. Being at night, maybe they couldn't get to the facility. They couldn't get transport immediately to the facility. General examination. The general condition of the patient depends upon the amount of blood loss. Shock develops if there is acute, severe blood loss. Anemia develops if there is recurrent, slight blood loss. But like the illustration I gave you, the story I gave you, is a true life story. It was continuous. Of course, there will be shock, and it depends on when they get to the facility. Abdominal examination. The uterus, usually, that is the fundal height, corresponds to the gestational age. The uterus is usually relaxed. It is not tender. Fetal parts and fetal heart sound can easily be detected. Malpresentation, particularly transverse and oblique lie. There could even be breech presentation. That is because the fetal head is being protected from whatever is blocking the passage. Of course, there is non-engagement of the head. This is because the lower uterine segment is already occupied by the placenta. Vaginal examination. It must be a speculum examination to exclude local lesions. And this is possible. You may want to use ultrasound because you don't want to cause any problem. Vaginal examination or examination per vaginum is indicated only if active treatment is initiated, because you do not want to provoke severe bleeding. And so what is this active treatment? The vaginal examination should be done in the operating room, under general anesthesia. At that time, you have already cross-matched blood ready. Operating theater is ready for immediate cesarean section. If the index finger is introduced gently through the dilated cervix, the placenta can be felt. Because it is a fibrous mass, it can be felt. Investigations. Using the ultrasound is the most simple, precise, and safe method of placental localization. A partially full bladder is necessary to identify the lower edge of the placenta. If it is less than 3 centimeters from the margin of the internal os, it is diagnosed as placenta previa. The posterior placenta previa is difficult to be identified due to shadowing from the presenting part of the fetus. This can be overcome by a head-down tilt of the patient. When that is done, it is displacing the presenting part manually. That is, you tilt the head downward. When you tilt the patient's head downward, you are able to manually displace the presenting part. If this difficulty still presents, the distance between the presenting part and the promontory of the sacrum should be measured. If it exceeds 1.5 centimeters, it means the placenta lies in between them. But for me, I will always say it. Once she is bleeding, please open her up. Give her a baby. In mid-pregnancy, the placenta reaches the internal os in up to 20% of pregnancies. With increasing gestational age, the formation of the lower uterine segment, a gap develops between the placental edge and the internal os. And what do we call that? Placental migration. Where you have, as the pregnancy advances, the lower uterine segment is now formed. So you have a gap at the edge of the placenta and the internal os. So we call that placental migration. So it is recommended to repeat scan when placenta previa is diagnosed. So at times, placenta previa is diagnosed in mid-pregnancy. So when you get to the 3rd trimester, where the lower uterine segment is formed, it is advisable to do a scan again to confirm the previous diagnosis. Treatment. When the patient is at home, we arrange for immediate transfer to the hospital. No vaginal examination, no vaginal pack. Only a sterile vaginal pad is applied. No oral intake, because you know that anesthesia will be required. Anti-shock measures like pethidine IM, fluids and blood transfusion may be given in the way to the hospital, particularly where you know that there is no danger. The question you want to ask is, from the home, where do we have blood transfusion? When we talk about blood transfusion from the home, when we talk about administering analgesics like pethidine as anti-shock, we are not talking about our own area here. Advanced countries, they have those things available. Because by the time she is talking of transferring, she has called the facility. And a skilled personnel could be invited to come. So when that happens, it is easy. Not for us here. Not at all. For us, number one, she should not be given anything to drink. There will be no pack at all. So when it is at the hospital, the patient is assessed, the general condition, abdominal examination, attempts to resuscitate her if possible. Then you could see that in the hospital, maybe prescription of at least 2 units of cross-matched blood is made available. And then the ultrasound is done to differentiate between abruptio placenta and the one we are talking about. Because for the abruptio, you will have the retroplacental bleeding in the normally implanted placenta. So you want to do that examination to know exactly what you are handling. Then, of course, assessment of fetal viability. You want to talk about the age. You want to talk about the position. You want to talk about the presentation. You want to talk about the fetal heart sound. All these are the assessment. When you have done that, then the management. If she is not in labor, consider the amount of bleeding. Assess the part. Assess her condition. If bleeding is severe, you continue with the anti-shock measures and a cesarean section is done immediately. If the bleeding is slight, how old is the pregnancy? If completed 37 weeks or 36 weeks, depending on who has examined because of the finger breadth, then pregnancy should be terminated by either induction or cesarean section. At this time, the fetus is mature and the mother will be in a risk of severe hemorrhage as term approaches. Now, if less than 37 weeks, conservative treatment is indicated till the end of 37 weeks, but not more. Patient is hospitalized with bed rest and observation until she delivers. If there be any anemia, it is corrected. Observation of fetal well-being, and then anti-D hemoglobulin is given for any rhesus negative mother. If this woman is in labor, vaginal examination is done under previously mentioned conditions or precautions, if you like. According to the findings, the patient will be delivered either vaginally, by amniotomy, including embolic drug, or by cesarean section. Vaginal delivery is allowed if the following findings are present. Placenta previa is lateralist or marginalist anterior. Bleeding is slight. It is a vertex presentation. The pelvis is adequate with no form of soft tissue obstruction. That cervix has started dilating, because it is when the cervix has started dilating that you can do amniotomy, artificial rupture of membranes. Amniotomy, we are told, has two benefits. Number one, it allows descent of the head, so it compresses the placental side. That is, if it is lateralist, preventing further bleeding. It abolishes the shear movement of the placenta during uterine contractions, as the bulging of the forebag of water during contractions with intact membranes will do what? Drag the edge of the placenta, invoking more bleeding. So you want to rupture the placenta so that you want to rupture the forewaters so that the advancing head will stabilize the placenta. It will not move. Cesarean section is indicated in placenta previa centralis, whether complete or incomplete, even if the fetus is dead. Because that woman is going to bleed severely. Placenta previa marginalis posterior, you know that the placenta is occupying where the occiput should have been. Where there is severe bleeding, presentation other than vertex, other obstetric indications as unfavorable pelvis, cord prolapse, elderly primate, vasa previa, short cord, and whatever. Note, although upper segment cesarean section is sometimes advocated, to be away from the placenta, lower section or segment cesarean section is preferable because, number one, it allows better control of bleeding from the placental site. It leaves a stronger scar that can withstand subsequent vaginal deliveries. if placenta previa was anteriorly implanted, it is gently displaced laterally to reach the fetal head. Otherwise, cut through it, not otherwise, to cut through it is not preferred. When you do a lower segment cesarean section, here are the advantages outlined. And that is why gradually the upper segment cesarean section has been abolished, because these ones have more advantages. The bleeding is controlled better. The scar is stronger and can withstand subsequent vaginal deliveries. And then the anteriorly implanted placenta is gently displaced. You push it aside to reach the fetal head. If you don't do that, you will now need to cut through the placenta to get to the fetus. Complications. To the mother, maternal mortality rate is about 0.2%, 0.2. During pregnancy, you could have this: abortion, preterm birth, antepartum hemorrhage, malpresentation, non-engagement of the head. During labor, you can have premature rupture of membranes, cord prolapse, inertia, obstructed labor, postpartum hemorrhage. Placenta could be retained. And if that placenta is retained, maybe it becomes a crater or something, it becomes difficult, except a cesarean section is done. And when the accreta is present like that, a hysterectomy is called for. Then you have lacerations of the lower uterine segment due to increased vascularity and friability, air embolism, a lot of things due to the low placental site. Now to the fetus. The mortality rate is 20%. There's prematurity, asphyxia, and malformation, which is about 2%.
My mission is to show you the powerful potential hardwired into the human DNA. And
Phoebe, your hand is raised, but yeah, there is noise in your background.
Sister, please let me mute it.
You say, go ahead.
On its experience, and through the experience, I want to ask a question. I had a pregnant woman who was in labor, 41 plus 6 days. So when she came and
she was
did
in
the
labor
assessment and everything,
hello,
the gestation week was 41 plus. Yes, sister, please, can you hear me?
I can't hear you well.
I said the woman was 41 plus 6 days gestation.
Okay.
So when she came, then we did assessment, everything was progressing well. So when she reached 7 cm, then she started bleeding heavily. So I positioned her to check. But after the VE, the blood was just gushing out. So I called the doctor. When the doctor came and he also did his assessment, he said we should refer. But when we referred and we got to the next level, there was someone already at the theater. So after they finished with that person, and my client was they were sending her to the theater, she delivered. But when she delivered, then the baby was coming. The baby came with the placenta. So I don't know whether the placenta was already detached in utero, or I don't know. That's what I wanted to know. If that one too could be
I want to get it clear. At the theater, did she deliver per vaginal?
Yes, mommy. She delivered per vagina because when we got there, someone was at the theater.
Okay.
We were delayed small. So
Okay.
during that the woman pushed through. But when
Okay. And she was already 7 centimeters gone
yes,
when she
yes,
started bleeding.
yes,
Then she
mommy.
must have had a placenta type 2.
Oh, okay,
It must have been type 2.
okay,
That was why the fetus would come out.
okay. But the fetus survived. The baby survived.
The baby survived, the mother survived. It
Yes.
must have been either type 2,
For 55.
but since you said the bleeding was severe, maybe type 3.
Okay.
That is centralist, incomplete centralist. Incomplete centralist because, but I'm surprised you didn't touch the tissue.
Yes.
Because it has reached 7 centimeters.
Okay.
It has dilated that much. So it has separated. That's why the bleeding is so much. I think it is type 3, but she
Okay.
is a very lucky woman.
Yes.
Yeah.
Okay.
Okay. Any other question? Phoebe, put down your hand. Any other question, please? I'm expecting questions. We still have about 45 more minutes. I will stop sharing for a while and bring another slide. So don't go, please be available. Good afternoon again.
Good afternoon, sir.
Good afternoon, Prof.
Good afternoon, Prof.
I told us that the semester is short. So we move. And since we are in a familiar terrain, familiar in the sense that this has been done in your diploma. So we want to look at cervical cancers. Cervical cancer is the third most common cancer worldwide among women. It is a disease that develops quite slowly and begins with a pre-cancerous condition known as dysplasia. Dysplasia is easily detected in a routine pap smear, and it is completely treatable. Cervical cancer is a malignant tumor deriving from cells. Cells of what? Hello? Am I alone in class?
Cells of the
We are here.
cervix.
Prof,
Yes,
you are
yes.
not alone.
House of the
You are not
service.
alone.
Something is
Sister,
covering
please,
that.
we are here.
Cells of what?
The service.
Cervix.
Okay. So when we want to talk about cervical cancer or cancer generally has their terminologies. We talk about biopsy, we talk about carcinoma in situ, we talk about colposcopy and dysplasia, as we have just talked about. That is abnormal cellular changes that may become cancerous. So for the other ones, we use them regularly in the service area. Hajara, can you mute yourself? So you see the anatomy there, you see the cervix, you see the uterus, you see the ovaries. That is anatomy generally of the reproductive organ. Then if you look to your left, the ovary has been brought out and labeled. Now, you are looking at the cervix when you view it from below. That is a female standing, the fallopian tubes are there, the uterus, the ovary, the cervix. And that is the area we are talking about. Cervical cancer. Cervical cancer is a malignant tumor deriving from cells of the cervix uteri, which is the lower part or the neck of the uterus. And the uterus, we all know, is the female reproductive organ. Causes. Number one, human papilloma virus. It's an infection with common human papilloma virus, which is always called HPV. And we are told that this is a cause of approximately 90% of all cervical cancers. About half of the sexually transmitted HPVs are associated with cervical cancer. Then sexual history. We are talking about causes. One is HPV. The second one is sexual history. A woman has a higher than average risk of developing cervical cancer if one, she has multiple sex partners. So she began having sexual relationship before she was 18. 3, she has a partner who has had sexual contact with a woman who has cervical cancer. Then other risk factors. Smoking, weakened immune system, several pregnancies, giving birth at a young age, long-term use of contraceptive pills, family history of cervical cancer. Danso, mute yourself. Bleeding that occurs between regular menstrual periods, bleeding after sexual intercourse, bleeding after douching, or bleeding after pelvic examination. Menstrual periods that last longer and have heavier flow than before. Bleeding after going through menopause, that is during menopause, and then increased vaginal discharge. Then, of course, you have pelvic lesions. Assessment and diagnostic findings. The pap test. Routine screening for cervical abnormalities can detect early-stage cancer and precancerous conditions that could progress to invasive disease. The process begins with a pap test, also known as a pap smear. Pap smear cells are scraped from the cervix and examined under a microscope to check disease or other problems. So like you can see there, it being scraped from the cervix. And then the lower one there, the cervix is being viewed through speculum with patients in a lithotomy position. HPV DNA tests. Yes. Like the pap smear, the HPV DNA test involves collection of cells from the cervix for lab tests. So you have the colposcopy. This is the colposcope that you use. You send it in there to illuminate the cervix. before biopsy is taken. And then the cone biopsy, that is cold cone biopsy.
And then every day this will happen.
You can see the large tissue around the cervix that is excised for examination. Look at it lying there. Look at the incision being done. And then the chest X-ray also helps. Then the computerized tomography scan. Then the magnetic resonance imaging scan. That's the MRI we are all used to. Then the pelvic ultrasound. Stages of cervical cancer. Stage 1, that cancer is confined to the cervix. Stage 2, it includes the cervix and the uterus, but has not yet spread to the pelvic wall or the lower vaginal area. Stage 3, at this stage, it has moved beyond the cervix and the uterus to the pelvic wall and the lower portion of the vagina. And then stage 4, cancer has spread to nearby organs such as the bladder, the rectum. It has even spread to other areas of the body, the lungs, the liver, the bones. How will it be managed? Chemotherapy is the most used chemical medication to destroy cancer cells. Cytotoxic medication prevents cancer cells from dividing and growing. Chemotherapy for cervical cancer, as well as most other cancers, is used to treat cancer cells that surgery cannot or did not remove, or to help the symptoms of patients with advanced cancers. You have the cisplatin, a chemotherapy drug, which is frequently used in combination with radiotherapy. Then you have the radiotherapy, which is known as radiation therapy. Radiotherapy works by damaging the DNA inside the tumor cells, destroying their ability to reproduce. For patients with advanced cervical cancer radiation, combined cisplatin-based chemotherapy is the most effective treatment. Then you have the surgical treatment, the laser surgery. A narrow beam of intense light destroys the cancerous and precancerous cells. Then you have the loop electrosurgical excision procedure, the LEEP. This is a wire loop which has an electronic current that cuts through tissue, removing cells from the mouth of the cervix. Then you have the cryosurgery. The cryosurgery actually is compressed nitrogen gas, which flows through the cryotube. It is a metal tube that freezes and destroys the abnormal cervical tissues. So that's the cryotube there that is attached to the compressed nitrogen gas. So when you pass it there, it freezes the abnormal tissues. Then you have the hysterectomy, total hysterectomy plus bilateral salpingo-oophorectomy. And then the last one, what? Something hysterectomy. What is that?
Subtotal.
Thank God you have seen. So the various types of hysterectomy that is done. Nursing management. Number one, dietary management. You have the flavonoids, which are chemical compounds in fruits and vegetables that are thought to be a leading source protection against cancer. These flavonoid-rich foods are apple, black beans, broccoli, Brussels sprouts, the cabbage, the garlic, the onion, the soybeans, the spinach. Then the folate, that is the water-soluble vitamin B. We are told it reduces the risk of cervical cancer in people with HPV. Foods rich in folate include avocados, breads, lentils, orange juice, and strawberries. Then you have the carotenoids, a source of vitamin A. We are told, yes, so. Thank you. They are also helpful in preventing cervical cancer. Then the carrots, the sweet potatoes, the pumpkins, we are told, are rich in vitamin A, which will help in preventing cervical cancer. And then you have the HPV vaccine. If every female adheres to current HPV vaccination programs, the total number of female deaths from cervical cancer globally will drop by hundreds of thousands each year. Safe sex, cervical screening, few sexual partners, delay first sexual intercourse, avoid smoking. I don't know whether to give you this assignment or not. Thank you. Now, talking about cervical cancer or cancer generally is a very important topic. And I have come to find out that the treatment is better amongst us than in the facility. Who can prove me right? Hello?
Hi, Prof.
Who can prove me right? The treatment of any form of cancer is with us. Can anybody prove me right? Hello?
Hi, sister.
Hi, sister.
Yes, I'm listening. Yes, please.
Sister,
Yes.
please, I can say I agree with you because it depends on our lifestyle, what we eat. Early detection, like going for screening and knowing our status, taking care of ourselves, like no smoking, practicing of safe sex, and all of those things is with us, rather than waiting to get the condition before going to the hospital. That's what I think. Thank you.
Can anybody, thank you for your contribution. Can anybody pinpoint categorically amongst the food we have what treats cancer even at fourth stage? Yes. Okay, to save our time, because I am conscious about, do you know that cassava, the cassava you and I know, can cure cancer totally? I will give it to you. Peel the cassava.
No, sister, we've not heard of it.
Huh? You say? Hello? Hello?
Hi, sister. We have not heard of it. I have not heard of it.
You've not heard of it. It's common. And that's why I was giving you the recipe. Peel the cassava. Wash it very well. Put it on fire. I think it is said that you boil it without covering it also. Once it boils, eat it. However you want to eat it. It is very good in the treatment of cancer. Coconut oil, coconut juice that, what do you call it now? The coconut water that we buy and drink is very good in the treatment of cancer. Take it regularly. And then the most powerful one is what you people call sweet apple, the soursop. Do you know it?
Yes,
Yes,
sister.
yes, please.
Yes,
That's
sister,
good.
I've heard of it before. The
Yeah.
soursop.
The soursop.
Yes, sister.
Even if it is stage 4, get the soursop. You may wish to blend it. That is, get it plenty. You blend it like cocoa, but you don't take anything carbohydrate, anything meat or anything. I don't know about meat, but carbohydrate should not come near. Take that alone, cocoa and beans. Prepare the beans the way you want, whether you want to cook it porridge, you want to boil it, you want to do kose, or however, just beans alone. And take that meal. By the time you take it 2-3 days, you will experience change. But eat it continually for 1 month. It eradicates the whole thing from you. We want to talk about cervical erosion. I don't have much time. If you will take what I have told you, you will be okay. Cervical erosion is benign lesions of the cervix. You have ectropion, you have cervicitis, polyps, warts. Then the Nabothian cyst, the myomas, the microglandular lesions, then the cervical stenosis. Cervical atropion is a condition where cells from inside the cervix form a red inflamed patch on the outside of the cervix. It is also known as cervical erosion. Cervical atropion is not usually health concern, that is, it doesn't cause harm. However, because of the way it looks, it can be hard to distinguish from the early stage of cervical cancer. For this reason, it is essential to understand the difference between these two conditions. So we are going to look at the causes, the symptoms, and the treatment of cervical ectropion. Cervical ectropion, also known as cervical erosion and ectopy, is a common condition caused when cells from inside the cervical canal, known as glandular cells, that is the soft cells now, are present on the outside surface of the cervix. Cervical ectropion can be caused by hormonal changes, number one, pregnancy, number two, and contraceptive pills. Ectropion is not linked to the development of cervical cancer or any other condition that causes cancer. That's why we are told that it is benign. So you see the normal cervix, and then you see the cervix of cervical erosion or ectopy. Causes. Some women are born with cervical ectropion. Ectropion could also be caused by hormonal changes. Cervical ectropion may be caused by a fluctuation in hormone levels and is most common in women who are of one, reproductive age. Two, women who have gone through menopause are rare, do not get this easily. I am numbering the hormonal changes now. It is either a woman is born with it or the woman has hormonal changes. And these changes are usually when that woman is of reproductive age. Get it clearly that cervical erosion that one is not born with does not come during menopause. Another thing is taking the contraceptive pills, the birth control pills, affects somebody's hormonal level and may cause this condition. And then the third one is pregnancy. Being pregnant may also cause cervical ectropion due to hormonal changes. The symptoms of cervical ectropion are caused by delicate glandular cells that appear on the outside of the cervix. These produce mucus and bleed easily, which may lead to spotting, pain during or after sexual intercourse. So you can see that the causes have nothing to do with HPV at all. It can be by birth, it can be by hormonal changes, it can be by taking contraceptive pills, or it can be during pregnancy. Risk factors. It is thought that cervical ectropion is induced by higher level of estrogen. Therefore, factors that increase the risk of ectropion are related to those that increase level of estrogen. That's why the pills common. Use of combined oral contraceptive pill, pregnancy, adolescence, menstruating age. So those are that. We are told, and we repeat, it is uncommon in post-menopausal women. Etiology and pathophysiology. The cervix, of course, is the lower portion of the uterus. It is composed of two regions, the ectocervix and the endocervical canal. The endocervical canal, that's the endocervix, it is more proximal and inner part of the cervix. And this is lined by mucus-secreting simple columnar epithelium. While the ectocervix, the part of the cervix that projects into the vagina, is normally lined by stratified squamous non-keratinized epithelium. In this condition, the stratified squamous cells of the ectocervix undergo metaplastic change to become simple columnar epithelium, the same as the endocervix. This change is thought to be induced by high level of estrogen. The columnar epithelium contains mucus-secreting glands and increased vaginal discharge. It may also give rise to post-coital bleeding, as the fine blood vessels present within the epithelium are easily broken during intercourse. This is the cause, and that is the pathophysiology, how it functions. When there is a displacement of the muscles or the mucosas of the ectocervix with those of the endocervix, you have that problem. And this comes on during childbearing age, during pregnancy, or when somebody is on the pills. Symptoms. The primary symptom of cervical ectropion is a red inflamed patch at the neck of the cervix, just as we saw it. That is the transformation zone. The transformation zone looks red and inflamed because the glandular cells are red. They are delicate and easily irritated. And that is why sexual intercourse could irritate it. Other symptoms a woman may experience include pain during sex, bleeding during after sex, light discharge of mucus, and spotting between periods. Excuse me. Some women will only have mild symptoms, while others experience more severe discomfort. It is important to note that cervical ectropion is not the only cause of symptoms. Please, excuse me. It is important to note that cervical ectropion is not the only cause of symptoms such as this. So if a woman has any of the above symptoms, it is a good idea to speak with a doctor. And this encounter will rule out more serious causes of these symptoms. Diagnosis: pap smear or pap test. This involves a healthcare professional scraping a small sample of cells from the cervix to test for HPV. Then the colposcopy. This is when a healthcare professional examines the cervix more closely with bright light and a magnifying instrument. And then the biopsy. This is when a small tissue is taken and tested for cancerous cells. A woman may experience cramping during the procedure. Holy Ghost, it's like I have talked too much. Investigation. Can somebody help me read?
Yeah. Investigations. Cervical ectropion is a clinical diagnosis. The main role of any investigation is to exclude other potential diagnoses. Pregnancy test.
Do you know what that means? That means is that when you see it, it diagnoses itself. But because we do not want to take chances, we can do others. Okay.
Pregnancy test. A triple swabs. If there is any suggestion of infection, such as purulent discharge, endocervical and high vaginal swabs should be taken. Cervical smear. To rule out cervical intraepithelial neoplasia, if a frank lesion is observed, a biopsy should be taken. Note that biopsies are not performed as routine.
They are not performed as routine, where a tissue has to be taken out of somebody's cervix. It's not the best. Go ahead.
Men. Cervical ectropion is not a harmful condition and does not usually require treatment. There are three different versions of cauterization therapy. Diathermy. This uses heat to cauterize the affected area. Cryotherapy. This uses very cold carbon dioxide to freeze the affected area. A 2016 study found this to be an effective treatment for women with cervical ectropion who were experiencing a lot of discharge. Silver nitrate. This is another way to cauterize the glandular cells. After the treatment, the doctor may recommend that a woman avoid some sexual activity and using tampons for up to 4 weeks. After this time, her cervix should have healed. If a woman experiences any of the following after the treatment, she should go back to the doctor. Discharge that smells bad, heavy bleeding, more than an average period, and then ongoing bleeding.
Ongoing bleeding, that is, you're bleeding continuously. So if a woman undergoes the treatment, she is advised to abstain from sexual intercourse for about 4 weeks because you want to make sure that there is a total healing. But if after all this she experiences a foul smell discharge, heavy bleeding again, or the bleeding is continuous, she should go back to the doctor.
Management. Cervical ectropion is regarded as a normal variant and does not require treatment unless symptomatic. First-line treatment is to stop any estrogen-containing medications, most commonly the combined oral contraceptive pill. This is effective in the majority of cases. If symptoms persist, the columnar epithelium can be ablated, typically using cryotherapy or electrocautery. This will result in significant vaginal discharge until healing is completed. Medication to acidify the vaginal pH has been suggested, such as boric acid pursues. Nursing management. Thank you.